It was in 1909 that Nobel Prize-winning German physician Paul Ehrlich proposed the idea that our bodies are fighting constant battles with cancer and that, thankfully, most of the time we win. Ehrlich was a visionary in recognizing the interaction between cancer and the immune system. Specifically, that cancerous cells are continuously arising in the body but that our immune defenses in many if not most cases keep them at bay. Enlarge this image. German physician Paul Ehrlich theorized that our bodies are always fighting off cancer and that usually we win. U.S. National Library of Medicine. Now, after his unrelated ideas sputtered along for decades, the theory is at the core of one of oncology's hottest areas, immunotherapy, or the mobilization of the human immune system to fight malignancy. Few would argue that in just the past few years this field has begun to transform cancer care. Newly approved immunotherapies have increased treatment options and improved patients' odds for a variety of tumors, while also allowing many with cancer to avoid, cut back on or delay chemotherapy. Former President Jimmy Carter's successful treatment for melanoma, including a regimen of immunotherapy along with radiation therapy and surgery, helped push the approach into the public spotlight. Yet immunotherapy has faced some prominent setbacks. In August, a clinical trial of the Bristol-Myers Squibb drug Opdivo, or nivolumab, for a group of patients with newly diagnosed lung cancer, unexpectedly failed as a first-line therapy. The announcement shaved $20 billion off the value of Bristol-Myers in a single day. Though immunotherapy is generally more tolerable than chemotherapy and radiation, there are side effects to consider. Immunotherapies can cause symptoms like fatigue, nausea and diarrhea, and a recent case report review revealed a possible link between the medications and chronic arthritis. And then there's the staggering cost, with some immunotherapies running well over $100,000 a year. The immunotherapy drug Yervoy, also from Bristol-Myers, is priced at $157.46 per milligram. To put that into perspective, that's approximately 4,000 times the cost of gold, Dr. Leonard Saltz, of the Memorial Sloan Kettering Cancer Center, said at last year's American Society of Clinical Oncology annual meeting. Perhaps the biggest question of all about immunotherapies is why don't more people respond to them? Data presented at this year's American Association for Cancer Research annual meeting in April showed that over one-third of patients with malignant melanoma who were treated with Opdivo were still alive after 5 years, more than double the 5-year survival rate for metastatic melanoma patients diagnosed between 2005 and 2011 who were treated with standard cancer therapies of the day. Yet as the ACR points out on its blog, despite the obvious cause for excitement, this means that about two-thirds of patients with metastatic melanoma who were treated with Opdivo had cancer that did not respond to the immunotherapeutic or progressed after initially responding. And response rates for other tumors tend to be markedly lower. In lung cancer, for example, they hover around 20%. Oncologists and scientists are now faced with determining why some patients respond and others don't, and also how to better predict which treatments are best for which patients. Equally important is understanding how the new treatments should be used with surgery, chemotherapy, and radiation, and whether or not, at least in some cases, immunotherapies can replace these more established,